Welcome. Good evening, everyone in Nasik. It's a pleasure to be here today. At the outset, would like to thank Dr. Siddesh, the whole ISHPT and the IMA Nasik organizing team for inviting us over here today. The title is What Clinicians Should Know. But what I discussed with Siddesh is, we will discuss some case studies. And we will discuss on a very basic topic like CBC, which whether it's a lab, pathologist, technologist, PG student or a clinician, we all use CBC. And like with our cars, we always want more mileage out of this test. So a simple test, I'll take you through a gamut of cases, maybe 5-7 cases as much as time allows, and see what all we can pick up in our daily routine. So in our lab, we do a test called as CBC Advance. This term was coined just that, we need to do a little more comprehensive CBC, and, we have moved away from the days of HP, TLC, DLC, but still today in a history, we get only those 3 values. In today's day and age, when you can easily have the WhatsApp of a printout or a printout submitted, we still get those 3 values. So in addition to all the parameters in our flag, what do we make use of? We'll make use of these flags which we get on our machine, like immature granulocyte flag. We look for malaria flagging. We look for flagging for thalassemia. We look for, NRBCs or immature grants. We do the peripheral smear evaluation in detail, and we also look at the reticulocyte count derived parameters, including retic, RPI, and IPF. This is the report, how it looks like. This is a routine CBC report on the left, peripheral smear, and then the retic parameters. And we'll discuss in the case studies as we go along. We'll try and make it a little interactive. So having inputs from the audience will be really great. So this is a young 22-year-old boy. This is the CBC done at the clinician's place itself. So machine is there, the clinician has seen the CBC. Hemoglobin was 12.9, a high WBC count 48,700, and a platelet count of 2,29,000. This is the straight machine photograph for you, and it was referred to us to evaluate obviously the peripheral smear. Now this is the peripheral smear over here. So this is the low power view, and the high power view, typically I said there's leukocytosis. And you are seeing a mixed population of neutrophils, metamyelos, myelopromyelos. There are some eosinophils there are some basophils around here. See, the basophils are here. So it's a leukocytosis, there is left shift, there is basophilia. I think one point, if I give you, there is a history of splenomegaly in this patient, though the age is young, and in India we do see this, we are already suspecting, is this a chronic myeloid leukemia, is the thing which is suspecting. So this was the CBC, the next day the CBC came to us, again very similar, hemoglobin of 12.3, WBC count had already increased in the last 2 days to 1 lakh now. There is a left shift, there is occasional blast, there is basophilia, occasional NRBCs, platelets are adequate. So immediately the clinician went ahead and did a bone marrow. So a typical test, one would think in terms of CML would be a bone marrow, a fish cytogenetic evaluation along with a biopsy. So we did that. Again, similar picture on the aspirate, hypercellular, increased MEX, left shift basophilia, and we confirmed the CML. Now this is not uncommon in routine practice for a routine lab to pick up, especially for hematologists this is very common. But that is not the reason I bought this CBC here. There is something more which can be seen there. So the fish was positive for 922, conventional karyotyping was done, additional mutation was seen, but again not very significant. Biopsy was done. Now biopsy is important in CML because we need to look for any clusters of blast and the reticular fibrosis at baseline. So we did the whole investigation setup as required, but there is something more in the CBC. So can anyone pick up anything else which we should be doing for this 22-year-old male patient whom we have now diagnosed to have CML? Anything in this CBC picture which you would like to suggest? So the hemoglobin is 12.3, RBC count 5.92, MCV 61, MCH is 20, MCHC is normal. Anyone, anything based on the hemoglobin and the indices would you like to suggest? If we ignore the WBC count, purely if the hemoglobin is there in a young male with these indices. So microcytic hypochromic indices with, you're looking at potentially a THAL trait, possibly with a high RBC count, a borderline low hemoglobin for a male. So this is also important because, while we are diagnosing the CML, not to miss out, this is important for him, the family, the siblings, you don't know the family history. So we said, there were target cells on the smear and we said we need to do. And immediately on our machine, this is the index which we have published. We use the Mentz's at the Sehgal index. It's already there in our machine. So what happens is there are rules which are inserted into the machines like flags. So you see this is the rule there. It says BTT positive. We have put this formula. It flags for the technologist and says this THAL index is potentially positive. This patient needs to be advised HPLC for further evaluation and confirmation. So this comes straight at a technologist level. So the pathologist also never misses it. So this was positive. Below 972 is what we consider as positive for screening by HPLC. So an HPLC was done. This is the graph. Now interestingly, the sickle window showed 19.4, the S window showed 19.4. The A0, which is the normal adult hemoglobin, is around 61%. A2 was 3%. We started thinking of beta thal trait, but we have an HBS. Now, this looks like an HBS trait because it is only 19% and A0 is above 60. But normally when we do HPLC for sickle cells, sickle is between 30 to 40%, the S hemoglobin, unless the patient is a disease and transfused. This guy had no history of transfusion, hemoglobin is 12.3. Now, but the indices which are microcytic hypochromic do not match with sickle at all. So, once you think why, in which other condition other than beta thal can you have similar indices, that is alpha thalassemia. And when there is concomitant alpha thalassemia with sickle, HBS values are known to be lower than 30. So we advise patient alpha thalassemia mutation studies. Okay, it was positive. So the final diagnosis for this 22-year young male is a CML-CP. He is a sickle cell trait, is also having an alpha thalassemia trait. All this is just a very rare case scenario where we picked all three together. The idea is not to pick all three. The idea is simply from that first CBC report, we could direct our thought process to different channels and different areas and diagnose this patient comprehensively. So that's the first case. We move to the next patient. Now this is a 6-month-old male child, came for anemia workup. Again, referred to a hematologist, was sent to us. We'll slowly go through the CBC. Again, the machine print is useful, especially in hematology, for both the clinicians and the lab. If they have access to the machine print, it gives more information. Hemoglobin is definitely low, 6.9. WBC count appears slightly higher, but remember this is a 6-month-old child. Up to 18,000 is close to normal. This platelet count was 287. Differential is not displayed here, was almost normal for age. Importantly, if you see on this side, the importance of doing a retic count upfront. The retic percentage was 11.91, and this is very high for this hemoglobin. So there's a retic response happening. The immediate plan from a lab point of view would be, just let's look at the peripheral smear. This is the peripheral smear. Anyone can tell me what we are seeing? Sorry? So polychromasia, these cells. So these are a lot of spirocytes. So not only are they round, there is no chromia, they are darkly stained compared. So if you see, this color is much darker than the RBC over here. So these are all spirocytes seen in this field. The platelets are essentially adequate. So in a 6-month-old child, anemia, reticulocytosis, smear is full of spirocytes. So what would we think of in this child? You will think of hereditary spherocytosis. Now, all of us, the moment we think of hereditary spherocytosis, the next test we think is osmotic fragility. And people in the lab who have done this test would know that this is a very cumbersome test. Practically in an ideal scenario, you need heparin sample. Very cumbersome to standardize. You have to plot these charts. It's a manual test, takes a long time. And you have a lot of borderline results. Neither is it very sensitive, neither very specific. If it works well, great. If it doesn't, it leaves still a gray area. So other than genetic test, are there any other tests? And this is what we have added in the lab over the last couple of years, which is called the EMA binding test. Advantage is simple flow cytometry based assay, a single dye, same sample which came to you for CBC, the same EDTA sample. You practically need only 200 microliters of blood, which becomes very critical in a young child like this, and that's why I showed you the example, and extremely sensitive with very good specificity. What do? We take 4 control samples. It may not be age match, but the sample age match. So if I receive a sample from Nasik, which is yesterday collected, from my lab, I'll take yesterday's sample. So that there's a sample's age is matching because you're using a dye banding assay. So what we do is these are 4 control samples. We use this eosin 5 dye, these are the RBCs which are gated. And in each patient sample, we measure the MFI, which is called the median intensity of that dye binding. We evaluate. This is the patient sample. And this plot is an overlay, 4 controls and the patient. So if you see the patient peak is to the left of the control peaks, which means the amount of EMA dye binding to it is much less. This is because of due to the typical band 3 protein deficiency seen in these patients. This is the way the report looks. So the reduction of MFI is 78%. Anything more than 21% is suggestive of HS. So same day, CBC, retic, straight away morphology and an EMA test, conclusively proving that this is consistent with HS. So again, a comprehensive CBC with retic count, with a smear, and this assay can be done to finish. Moving to a slightly more complex case, again the CBC will highlight, starting from the CBC, the gamut of investigations in a hematopath lab and a discussion with the clinician that requires in such scenarios. So an elderly male had anemia, hemoglobin 10.1, WBC count was okay, 11,540, but had thrombocytopenia, was fluctuating between 80 to 1 lakh overall counts, had definite monocytosis, not very well seen in this picture, but the patient also had hypogranularity in the myeloid cells and dysmyelopoiesis, even on the peripheral smear. Based on this, we advise a bone marrow, a packed bone marrow, and I will show you some images over here. So if you see, there is a left-shifted myelopoiesis, there is a lot of hypogranularity in the cells. This is like a hypolobated maturing myeloid cells. There was dyspoiesis, peripheral monocytosis, there was low platelet. We are thinking slightly higher WBC count and dyspoiesis with monocytosis. So is it an MDS-MPN overlap? Suggestive of CMML. Now, monocytosis we see very commonly, especially in this season with viral fever and reactive. So 2 things I will tell you. There are 2 criteria of monocytosis that should be fulfilled. We always stick to the absolute monocyte count more than 1,000, but the monocyte should also be more than 10%. Otherwise, in the previous case of CML, which has 1 lakh count, and if I have 2% monos, I have crossed 2,000 count. So that should not be the case. FISH for BCR-ABL has to be negative. Typically, dyspoiesis is extremely common both on peripheral blood and marrow morphology. Again, we did the biopsy, features are all there, but we advised cytogenetics. That is very critical. For some cost issues initially, the patient just did a basic FISH for MDS was negative. A karyotyping appeared normal. Patient was treated with azacitidine. Did not improve much. Moved the physician. From the second physician, we fortunately got the marrow back again to our lab. Similar picture on the peripheral blood, repeat marrow, similar picture on the marrow, dysmyelopoiesis, monocytosis. This time the bone marrow biopsy was interesting. We found these clusters of spindle cells which were not reticular fibrosis. We did a 117, bright positive. These are all mast cells. The mast cells were there even in the previous picture in the second marrow. These are the mast cells on the aspirate. On retrospective analysis, when we went back to the first marrow and the first biopsy, there were few mast cells, but not like in this biopsy. So at this point, we had already ordered a next generation sequencing for all mutations. We had ordered for a cytogenetics, and we had this potential of mastocytosis. So you need spindle cells. These spindle cells were positive for CD25. I don't have an image for that. They were negative for 2. They were clusters of spindle cells, which fulfills all the criteria for systemic mastocytosis. And on the NGS, we had the KIT mutation, which is very specific, seen in these disorders. So the final diagnosis, which is rare, but if we don't look for it, we won't pick up, is a systemic mastocytosis and an associated hematological neoplasm. And actually the most common hematological neoplasm we see in this patient is CMML. So again, the monocytosis, the dyspoiesis seen on the peripheral smear, the slightly higher WBC count, and the thrombocytopenia is where all the journey of this patient started. And then doing the complete gamut of investigations which is required to reach this rare but important diagnosis. So after a complex case, I will move to something a little simpler and back to something which we'll be seeing more often in this season. But for the sake of the PGs in the audience, I'll discuss the concept of lymphocytosis. This is just a manufactured case on the left and the right, everything is the same. Here WBC count is 3,500, here it is 35,000. The lymphocyte percentage is same, 65. This is, when you see this 65, this is relative lymphocytosis. And when you see this 65, this is absolute lymphocytosis. This is very important because as pathologists in the lab, sometimes we just write the word lymphocytosis and it can be misinterpreted in different ways. So an absolute lymphocyte count of less than 5,000 relative, especially when it is with leukopenia and neutropenia. An absolute lymphocyte count above 5,000 is absolute lymphocytosis. So this is very critical to differentiate. The criteria in the guidelines is more than 5,000. Now, if you have absolute lymphocytosis, is it transient or sustained? We know in a patient of dengue, you can see almost close to absolute lymphocytosis. Infectious mononucleosis, it's very common. And especially in infectious mononucleosis, the counts persist, the lymphocytosis persist for almost 2 to 4 weeks, depending upon how severe the disease was. So is it sustained or transient? If sustained, is it benign or malignant? That's the process which we would like to follow. So if you get a case of lymphocytosis, typically the clinician will, as a clinician, you will look at all the histories. Typically, as I said, viral infections, dengue and, infectious mononucleosis or other viral infections which we might see, autoimmune disorders. Not uncommon, and that's why I would like to highlight smoking, drugs. These are very common issues, especially also in the elderly. We see a little bit of LGL, reactive conditions, autoimmune. You do see a little lymphocytosis there. So keeping this background of lymphocytosis in mind, I wanted to present 2 case studies highlighting that every lymphocytosis is not CLL. Because the moment we see lymphocytosis, 20,000, 30,000 count, it gets labeled as CLL on the report and it says, okay, we can wait and watch. But lymphocytosis could be very different. So I'll highlight that with a couple of case reports. So this is a 72-year-old gentleman who had persistent lymphocytosis with mild anemia. And previous WBC counts were ranging between 12,000 to 9,300, high to low. And lymphocytes were hovering around 42 to 58%. At many times in the report, it was above 5,000, the absolute lymphocyte count. So the hematologist wanted to just rule out any lymphoproliferation and said, kindly do the flow analysis. So what do we do in flow essentially is we get our lymphocytes based on CD45 plot and we divide it broadly first into B, T and NK cells. Of the lymphocytes, B were 36%. The T in green, CD3 positive are here and the NK which are 7 positive, 3 negative are the NK cells which are only 4%, T are 60%. This is almost like a normal percentage of T, B and NK. To see whether these are abnormal B, T or NK, we need more markers. So here, if you see the B cells are now divided into 2 colors, the ones in blue and the ones in red. If you see the blue cells are 5 negative and the red cells appear to be 5 positive. If you form a cluster of 5 positive B cells, we need to look at clonality. So we looked at kappa lambda. So the blue cells are nicely polyclonal on kappa and lambda. So these are the normal B cells. The red cells are all bright lambda positive. This is a lambda predominant cluster, but a very small part of the whole cells. It also had some expression of CD23. So we are looking at a 523 co-expression with a lambda clonality. And we know this is typically, this patient also had 243, which is a typical phenotype of CLL. Okay, but there is a catch here. When you see the absolute lymphocyte count, yes, it was above 5,000, but that is the total lymphocyte count. B cells were 36% of all lymphoid cells, and we saw some of them are actually polyclonal. Assuming all B cells for sake of calculation were clonal, the clonal population would be only 1953 cells per microliter. And the WHO current definition of CLL is the clonal B cell should be more than 5,000. So here the clonal B cells are less than 5,000. So this fulfills the criteria of monoclonal B cell lymphocytosis. Again, this is not a cancer. It may be precancerous, but not in all cases. Now there is low MBL, high MBL. The idea is we need to identify this, and if we start doing this in elderly population, the number will be very high. Some European studies have proven this number to be between 2 to 5% of people above the age of 65. If you start picking up even minute, less than 1% population, that is. However, anytime you pick up MBL, it should not be that patient has lymphadenopathy, has a disease elsewhere, has a previous disease, and there is a whole list of criteria which needs to be followed, that there should be no underlying disease in the bone marrow or lymph node and you are picking up a small cluster in the peripheral blood. That has to be ruled out. So this patient is kept on follow-up, has to undergo certain examination, and all these criteria then go into a report, and the clinician obviously is discussed, and then you take this forward. Now this is another example, something in a similar line of things. Here the WBC count was 16,000, hemoglobin is close 11.4, a mild anemia, and the absolute lymphocyte count was 9,000. Lymphocytes were around 55%. So this has been persistent lymphocytosis last couple of reports over a period of 1 month. Definite leukocytosis with lymphocytosis. We saw the smear referred to us. Nothing very, very unusual, but yeah, some of the cells, subtle clefts, subtle lymphocytes. But frankly, you show me this morphology without the CBC report and the count, I might let go it off as, close to almost being normal reactive lymphocytes. Very closely, some of the cells have clefts, so you are suspicious. Again, we did a flow. Just for the sake of colors, the green cells are the 5 positive T cells. The brown over here are my normal B cells, and I have 19 5 expressing B cells again. So again, I'm showing you a 19 and 5 cluster. Here the lambda is bright, 38 is moderate. There is a very dim uniform 43. The 200 was negative, 23 was negative. Generally, a CLL, which is a 5 positive B cell lymphoma, has dim 20, here it's a bright 20, has a dimmer light chain, this is a bright lambda, has presence of 200 with 43, here the 223 are absent. So we are thinking of a 5 positive B CLPD, which, this was 90% of all the lymphocytes. It's crossed the criteria of more than 5,000, but it is not a CLL. So the other 5 positive B CLPD with bright 20 is, anyone in the audience? Somebody said it louder. Mantle cell lymphoma. So the mantle cell lymphoma confirmatory test would be a cyclin D1 either on IHC, ideally by FISH. So we did a FISH for T11, 14, and you see it was positive. So simply purely on the CBC, a peripheral blood flow and a peripheral blood FISH, we have a diagnosis of a mantle cell lymphoma, very different from prognosis from a CLL. So just lymphocytosis is not CLL, it could be an MBL, it could be a mantle, it could be a marginal zone, it could be some other phenotype. These two cases were just to highlight in a clonal population, non-benign lymphocytosis, you need a complete gamut of test again to reach a conclusive diagnosis. With this, I'll move to the last case of the day. Again, we'll try and keep it interactive. So this patient has a hemoglobin of 13.5, a high platelet count of 7,40,000, and a high WBC count of 20,000. Okay. So some questions for the audience. We started the first one. Does the patient have microcytic hypochromic anemia? Yes. So I'll break the question. Does the patient have anemia? Male patient, hemoglobin 13.5. So hemoglobin wise there is no anemia. But does the patient have microcytosis hypochromia? Yes. Correct? So that is there. Now typically when we say microcytic hypochromic, and RDW, which is, in this case it's high, but with an RBC count which is very high, would one think of beta thalassemia trait? There is no anemia, a microcytosis, a high RBC count. Sometimes you will think, you will say, let's calculate the Mendel's index. Third question would be, does the patient have iron deficiency anemia? Because the RDW is almost 27.9. Normally in thalassemia, we say RDW should be close to normal. But what if the patient has thal and iron deficiency anemia? But the hemoglobin, again, there is no anemia, I said. So there are questions in the CBC which are unanswered. So, yeah, please go ahead.
This patient has a congenital cyanotic heart disease.
Okay.
And his hemoglobin might be 13.5 along with iron deficiency anemia.
So a great thought. And I think you're in the right direction that you're thinking of polycythemia. Okay. The two odd things for that thought process would be a WBC of 20,000 and a platelet of 7,40,000. Those are also a little bit clues that this patient is something else. Now, two things I want to highlight. Iron deficiency anemia can have reactive thrombocytosis, and we see 4 lakh, 5 lakh, 8 lakhs also. Okay. So again, the hematologist saw it. This is the whole CBC in front of you. We did the indices, and it does fit from the indice point of view. Okay, it could be a thal trait. Ferritin was 4.5, it was low. Vitamin B12 was normal. LDH was almost normal. Practically there is no significant change. HPLC is already done. The HbA2 levels were normal. And a USG abdomen showed a mild splenomegaly. So the importance was this patient had leukocytosis, a little bit of basophilia, a mild spleen, a thrombocytosis. But the RBC count is very high, 7.94. In practice, in thalassemias, we typically see RBC count of 6 million, 6.5 million. I have seen only one case practically in so many years of experience up to 7 million, but not more than that. Okay, anything in the range of 7.5, 8 million, you're thinking of a polycythemia. So sir said, right, the question is polycythemia with an iron deficiency anemia. But of this list, what would be the test you would ask for? Fish for BCR-ABL, JAK2, conventional karyotyping, all of the above. Anyone from the audience? We are suspecting a polycythemia with leukocytosis and a thrombocytosis. This is more likely to be a primary polycythemia and not a secondary polycythemia. I would do all three. The reason for that is you require first to prove it is negative for CML, though the picture doesn't look like that, but that's the WHO definition. A JAK2 and related disorders like KELR, MPL, JAK2 exon 12 will be required. You need to do a baseline bone marrow and a conventional karyotyping. We did the marrow. It fit in the features of pan-myelosis, and I'm not going to detail that over here. There was clustering of megakaryocytes. There was no increase in reticular fibrosis. Both very important document at baseline because these patients might progress in the future. And the JAK2 was positive, the fish was negative, the KELR was negative. The karyotyping was done again at a baseline. So this patient is a case of polycythemia with iron deficiency, which is sort of compensatory by the body. Now, why do we tend to miss this? And this is not an uncommon scenario in our country, specifically in our country. Typically, you will say the criteria says hemoglobin more than 16, 16.5. In our country, we'll see patients at 13, 14 also. Especially females might be at 14, 15, males might be at 13, 13.5, 14. They look normal. So please focus on the RBC, WC and platelets and not to miss a hidden polycythemia purely because the WHO criteria says 16, 16.5. So this was very important take-home messages. They can present at lower than defined hemoglobin thresholds. These thresholds for HB and HCT are not meant to be screening tools. Not every patient of 16 may need evaluation with a marrow and everything, but a patient with suspicion, you can do a JAK2 and a EPO level from peripheral blood itself. If the picture matches, then you should start thinking of polycythemia vera, and in consult with your hematologist, you can diagnose this condition. With that, I'd like to thank you for your patient listening, and I'll be happy to take any questions from the audience. Thank you so much.